Thank you all for joining us in this session, which is part of the Georgetown-Lancet Commission on Faith, Trust, and Health webinar series. My name is Diana Reyes. I am the Program Director for the Faith and Global Health Initiative within Georgetown's Global Health Institute. Our initiative aims to advance health equity by strengthening partnerships between faith communities and global health systems. One of our first and most ambitious efforts is the Georgetown-Lancet Commission on Faith, Trust, and Health. This commission brings together perspectives from both public health and faith traditions across the global North and South in order to create a space for research, dialogue, and collaboration to reimagine health and well-being globally. As a part of that broader effort, today's conversation centers on a vital yet often underexplored dimension of mental health and psychosocial support, the role of faith. In many communities around the world, faith, or feelings of spirituality and religiosity, are not separate from health, rather, they are integral to it. This is especially true when it comes to mental health and well-being. Faith is deeply intertwined with how people understand suffering, resilience, healing, and hope. It also greatly influences when, where, and whether or not individuals seek care and whom they trust along the way. And yet, mental health systems have not always met people where they are. Spiritual and religious perspectives are frequently treated as secondary, when for many they are foundational and central to their lived experiences. The result is a quiet and significant gap, not only in access to care, but in its relevance, its acceptance, and effectiveness. Today's session brings together voices from mental health practice, academia, and faith communities to explore a different path forward, one grounded in collaboration, mutual respect, and a shared commitment to supporting the whole person. This reflects the principle of cura personalis, a value we hold deeply at Georgetown, and one that calls us to care for the whole person, mind, body, and spirit. By recognizing both the psychological and spiritual dimensions of care, we have an opportunity to build systems that are more trustworthy, more culturally responsive, and ultimately more compassionate. It is now my pleasure to introduce our moderator, Catherine Marshall, who's a senior fellow at Georgetown's Berkeley Center for Religion, Peace, and World Affairs, and professor of the practice in the School of Foreign Service. She is also an esteemed member of our commission and a leading voice at the intersection of development, religion, and global health, bringing decades of experience in global governance, humanitarian work, and the role of faith in development. Catherine, over to you.
Good morning, good afternoon, good evening. Speaking from Washington, D.C., delighted to moderate this panel. We have two extraordinary colleagues who have decades of experience working on the topic that we're concerned with today. So let me start by introducing them and then put questions to them. Alistair Adger has had over a long career many different hats, but now he's the emeritus professor at Queen Margaret University, based in Edinburgh, and has worked on the issues of mental health, both in research and practice, in many different parts of the world. And Rania Awad is a clinical professor of psychiatry at the Stanford University School of Medicine. She's director of the Stanford Muslim Mental Health and Islamic Psychology Lab. And she's also Stanford University's affiliate chaplain. So the basic question that we're asking today, the commission that Diana spoke about, is focusing on health, on trust and health. And we know that faith leaders, religious communities are often the first place that people turn to when they experience distress. And yet the roles that faith actors play within broader mental health and psychosocial systems are not often as clear as they might be. And often within religious and spiritual contexts, there are very different understandings of mental health. So we want to explore those issues. So let's start turning to Alistair and ask him, why is this, and what is the challenge that you see, and what are some experiences of the ways in which organizations can engage religious actors respectfully, and I would also say vice versa. So over to you.
Thanks ever so much, Catherine, and thanks all for convening this session. Very happy to contribute. I find the first question particularly interesting in terms of framing it in terms of that broader mental health and psychosocial support system. And the last 10, 20 years, I think I've adopted a systems approach like many researchers in this and related fields. And for me, the lens that we use to understand what actually is this system that supports us in our mental health and well-being is really important. And from work that I've completed as a researcher in settings as diverse as Sierra Leone and Lebanon, but from my own experience as living, whether it's here in Scotland or living in Malawi or living in New York, different habitus environments for me, it's very clear that the formal mental health system plays a crucial but potentially very small part in a much larger system of support for our health and well-being, particularly when we understand, as Diana said in her initial remarks, that our health is constructed not just as our physical health and mental health, but the social and spiritual elements of that as well. So I think if we have that broader systems lens and we try to think of the multiple influences upon our health and well-being and where we might seek assistance and seek support, many people familiar now with this rather strange acronym of mental health and psychosocial support, MHPSS, that whole field has really come about because of a conflict between a much more clinical understanding of mental health as a personal biological event and a much more social understanding of the influences on well-being. And I see MHPSS as a huge success in forging different areas of science, but also different areas of our experience together. So that clearly, and Rania may well be talking about this later, there are opportunities to inform specialized mental health services with a particular religious faith lens. But we need to understand that before many people get anywhere near that sort of service provision, we're in social contexts where our relationships, our families, our wider community are hugely influential on our well-being. And this ISC, International Agents Standing Commission committee pyramid that many people will be familiar with. If you're not, look it up later. This MHPSS pyramid very much puts the importance on specialist services at the top of the pyramid, but the foundation is very much around strengthening community and family supports. So I think it's really important, Catherine, that we start our conversation not in a clinic or not with a disorder, but with someone who lives in community, in family, in society, and how they understand their mental health and well-being. And as Diana said in her opening comments, once we have that community lens to understand the lived experience of mental health, inevitably in the majority world, the faith experience, the faith actors within institutions are hugely influential in shaping some of the challenges to mental health, but also the resources to address it. So that would be my first comment, Catherine, is just to make sure that we frame the mental health system as one that doesn't just have some side edge, some end point linking to these local supports, but fundamentally sees that as the principal area where we forge our well-being. Sorry, Catherine, you were going to come in.
Do you have an example of where this might have been done positively, or if just to give one or two to anchor us a little bit in something that has some geographic or institutional focus?
Well, I mentioned Sierra Leone and Lebanon, and again, to be honest, I don't want to make this an exotic or geographical example, because I probably could draw upon examples from Edinburgh or New York similarly. But in those contexts, we studied at local levels. Let me choose Sierra Leone as an example of where do people go to when they're experiencing some degree of discomfort, and or members of their family who are concerned for them. Now, unsurprisingly, that's usually local institutions, and predominantly in Sierra Leone, where we were working, that would be a potential religious actor or faith actors there. Now, we didn't want to romanticize that, because sometimes that support could be helpful, and sometimes it would be encouraging in terms of social engagement. Other times there was a danger that people would stay at that level and be experiencing significant mental health issues and not be able to access, in Sierra Leone, a rather fragile and rather small mental health sector. but very much linked to the objectives of your commission, I think, the role of trust proved very important. Do you really trust going to a clinic, or do you trust this provider to go and share something about your experience? And what we found was a very clear linkage between institutional trust, whether you trusted a program, whether you would recommend someone to go to a program, and two other forms of trust. One, the trust of a particular provider, which is just the personality, the sense when someone went to a service, were they treated humanely? And in this particular context, I'd say, would their faith experience be taken seriously? Would they be understood within their own cultural milieu? That interpersonal trust bolstered and potentially could support an institutional trust, but also what we call the social trust, which is that a community can work together to encourage people to access services and say, we have found that helpful, this is useful, this is congruent with our beliefs. And so strengthening local provision of mental health services in parts of Sierra Leone, including through one of my students, Abdullah Ba, in terms of women's perinatal mental health experience, working with local providers and lay helpers to understand experience at a local level, potentially to provide social solidarity, encouragement, etc., but also then potentially to provide a route towards referral to more formal services. And all of that based upon a properly contextualized cultural understanding of mental health experience. And in many settings, as Diana was hinting at the beginning, an appropriate cultural understanding is to reflect the embeddedness of religious understanding and experience. And that's something that can be freely spoken about and addressed.
Well, thank you. That's very helpful and takes me right to first question for Rania. What do you see as the skills that are involved? And that would be, I think, skills for public health or health personnel, but also for the religious communities that would help to bridge some of the gaps that we know exist between the public health and the religious worlds. What are the skills and avenues to build them that you would see?
Yeah, thank you. And first, I'd like to just say thank you for having me here. And I'm very happy to see that this topic is being discussed. And I really appreciate the comments Dr. Adrian made just now. Yeah, happy to address this a little bit further. To think about how, if we think about faith leaders and community leaders as partners, in particularly here, I'll speak to mental health, because there are specific reasons why, if I look at the research we do with the Muslim communities, what is it that prevents people from getting those, whether they be public or private services related to mental health? And often it's mistrust of service providers, fear of treatment, fear of racism or discrimination amongst, that they would be discriminated amongst. Sometimes it's more logistical. Sometimes it's language barriers or a different way in communicating. The language, the very language being used is different. It isn't scientific, medical, mental health language. It's said in a more spiritual way, or it's said in basically a layperson way of expressing what it is that's hurting them or bothering them. And so very often there needs to be middle folks, or I would say in all of our research, when we ask folks questions like, who would you go to first, second, or third, if you felt that you or your loved one had a mental health concern? And every single study we've done this over decades now has come back where the mental health providers at the very bottom of that list. They don't show up at the top. There is some intergenerational changes now. There's some generational changes, I should say, that are happening now where maybe it's becoming more that people will go directly to a mental health provider, but that's definitely not the case worldwide just yet. So what do these middle folks, or maybe I should call them early frontline supporters do, and what can they help with? Oftentimes it's speaking the same language of their communities or the congregations that they that they minister to or that they take care of. And so being able to then broker that conversation, do the warm handoff to the mental health professional or professionals in this case, be able to help them interpret that distress in other ways that are actually less spiritual and perhaps more medical, physical, scientific in some ways, but that requires the religious leaders themselves to be trained, which is the point I'll come to later. And also having themselves had a positive experience, that they themselves trust the systems with which they're referring or giving that warm handoff to their congregation to. So that is really important. I think all those aspects come with training and with trust, and with an integration that isn't always there, unfortunately. In some contexts, but not always.
Mm-hmm. So what are examples that you've seen that seem to work, that help to bridge some of these gaps?
Yes, I can speak to our local context here. I'm in the San Francisco Bay Area, in California, and about 15 years ago now, we set up a CAB, a Community Advisory Board for Muslim mental health. And this comes directly from public health work and research. The idea of having it be community facing and something in which community leaders are the ones who lead the discussion. The academic partners, in our case at Stanford University, are the helpers in the background, but actually the community is the one that leads this work. And this CAB of Community Advisory Board of individuals were all different people. Amongst them were faith leaders, amongst them with other folks who care deeply about mental health issues, but they're not themselves practitioners. And they were from many different ethnic backgrounds. They spoke different languages. They were from different parts geographically of our area here in the Bay Area. And they were able to get to the different corners, if you will, of the community, and be able to advocate on what it is their communities, their sub-communities needed. Also, be able to bring to the table conversations that we probably wouldn't have heard otherwise, whether in an academic, clinical, or medical space. And the formation, what was formed from that group was some really excellent things. The first Muslim mental health clinics, for example, were formed because of that group. A directory of mental health providers, for example, that hadn't been there before. Nobody really knew where to go if they wanted to go to the mental health system, putting a directory together. Also having more specialized and nuanced conversations with local schools, like Islamic schools, Sunday schools, places where people don't normally think this is where we should go to have these conversations, but absolutely mental health exists in all these corners. Yeah. It just wasn't being brought to the table.
Well, I think you have a special expertise in this question we're all wrestling with, which is what's faith literacy, but also what's public health literacy.
Correct.
So let's go back to Alistair. We were talking, I think you were talking about what you might almost call normal situations, which would be true in Washington, D.C., San Francisco, Edinburgh, Malawi, perhaps South Africa. But what about crisis situations and the issues of mental health? I know you've given a lot of thought and attention to refugees, to the traumas that children face, and the kinds of crises that sadly are far too common in today's world.
Yes, Catherine, I think it's both a special area, but also illustrates many of the themes that we've already touched on just generically. Mm-hmm. And for me, one of the key echoes of that work is around the engagement at the international technical level with the local and contextual. It's a familiar dance in international development work of how we have these drivers and promoting things and adding resources, which is valuable, but how that's done in a way that respects and understands local context and local agendas. And that's now very commonly framed with respect to the localization agenda and informed about how we, particularly given the pressures on international development assistance, the value of local resources. So I think in those crisis situations is pushing us in the direction that Rani is already hinting at about mapping existing resources within communities and empowering groups to be active at a local level. But I do think in the international arena, there has been a particular way that this dynamic has played out. And I want to suggest that there's really two agendas there that have been quite significant. One, which I think is broadly relevant as well, conceptual, philosophical, indeed theological, about the nature of faith and religion, and another that's very political and pragmatic. So let me just briefly outline those two to answer your question. I think for many years, the humanitarian system has dealt with religion largely by ignoring it, to keeping it out of the room. This maybe or maybe not has suited intergovernmental multilateral discussions where religion has been seen as potentially a source of conflict or division. So we don't get into this. But at the level of programs, context, beneficiaries, we've already spoken, that makes no sense. And it means potentially programs are deaf to the needs of that, which are framed for many populations in terms of their experience of faith. And for me, it's only really in the last 10 years, I think you actually have to say, Catherine, you did some very important pioneering work with World Bank and others to understand the potential deafness or blindness to the huge resources brought through faith actors. And in the humanitarian space, I think it was Antonio Guterres in his previous role as High Commissioner for Refugees in 2015, so just over 10 years ago, in convening a dialogue on faith and protection, which I know scared a number of senior policymakers of having the UN High Commissioner engaging directly with faith actors. And his claim that UNHCR, to be a secular organization, does not mean it should ignore religion, but must respect and value faith of the people we care for, and engaging with it. Now, to be honest, there's been much work I perceive there's been a shift over the last 10 years, such that the presumption that you can ignore religion, the presumption that a rational humanitarian approach can leave that to the side, has lessened significantly. And I think we're in a very different space where we're much more open through Religions for Peace and many other organizations to mobilizing. But I still, frankly, find that specter of a presumption of secularity, a presumption of Western secular liberalism, if you like, in a number of agencies. So I wanted to mention that. It's a war against presumption. I think that's the word. It's not ignorance. It's a presumption that really at the end of the day, we know we don't need to engage with religion or that will be dangerous. And I think we know that world is over. And it's really important to see that we need to challenge the assumption that religion, to be deaf to religion, is to be neutral. It isn't. But that then takes us, I think, to the much more challenging area in many ways of the political and the pragmatic. It's about actually in a humanitarian situation in Chad, where I'll be working with colleagues in the coming months, supporting mental health service provision to those displaced by conflict, how to work with local providers and how to deal with the religious experience in a way that is supportive of human rights and certain principles.
Right.
And for me, there's good development practice in there about engaging multiple stakeholders, exactly the sort of process that Rania described working in the Bay Area, of understanding that in Chad, we will not be able to work with all stakeholders, but we cannot be blind to religious actors. We will not be, we'll be aware that not all those religious actors would freely come together, but because it's difficult, doesn't mean that we don't do it. We don't not engage with gender because it's a controversial subject. We know that gender is a fundamental dynamic in humanitarian conflicts, and we engage in the complex local work to engage with that. And I think that's what I'm beginning to see emerging now, of a readiness to engage with religion and to see the potential strengths and resources that it brings, and also to be open enough to acknowledge the challenges, the tensions, the uncertainties that it creates, but to work through those in terms of strengthening humanitarian programming.
Well, I think you've made a raft of important points, including the complexity and which brings me back in the sense to the question to Rania of how do you build the kinds of sensitivities and skills that are needed to do this well. But just another question that your question also raises for me, that we've seen substantial changes over the past decades. And that's true, obviously, in approaches to religion as an actor in public policy matters, but also to mental health. So I'm interested, Rania, in how do you see generational shifts in approaches to mental health? And can you point to any of those that are really part of sort of the religious landscape as well as to the sheer public health, but also public consciousness dimensions of thinking about mental health?
Absolutely. I would say the marker for me has been the COVID-19 pandemic. It's in many ways, I think what the pandemic did, if there was anything positive that came out of the pandemic at all, would be this awareness. Suddenly there was an awareness much more than before on mental health and its importance, and just being a real entity that actually takes hold. And I think there were many folks who from an earlier generation who may not paid attention to mental health, or maybe from other sectors, including the faith sector, who then realized actually this is really important. And if we don't address this, we're going to see a surge. And in fact, we did see a surge, and we continue to see a surge in mental health concerns across many generations, not just youth. But certainly that the language of mental health, the public awareness around it, the public messaging around it has been very interesting. We have a line of work that's focused on students and on youth in particular. And it's so interesting to see this generational shift in which the language of mental health is very comfortable for them. They speak in this language, they understand this language. And if somebody tries to minimize it, they are very upset by it. And so there is, in fact, some generational shift that we're seeing. And because of that public consciousness, whether it be your, famous entertainers, athletes, people who have major platforms, whether that be on social media or otherwise, speaking about their own mental health journeys and struggles, and normalizing the conversation, we have found that started to happen even in corners where we wouldn't have expected it. Faith communities would be one of those corners. The number of khutbahs, which are the Friday sermons, for example, for Muslims that I have seen now in mosques, in which there is a discussion on mental health that enters into the sermon space, is incredible. So definitely something I did not experience growing up, and seeing more and more of that happening. Programming, whether it's family night, community nights, discussions, inviting mental health practitioners into those spaces. So I appreciate those changes. I know we still have a very long way to go, particularly on a global level, to have that conversation really seep into all different corners. But it's happening. And I think that's a welcome change from when I first started in this field.
Would you venture any generalizations related to religious communities? Because clearly that's a very ancient matter, is how mental health in all of its dimensions is part of one's spiritual nature. But do you see the changes that you describe in the broad sense within specific communities? I know that's a tough question, but because it's a huge world that involves.
It is a huge world. It is, in fact, a huge world.
That's why I'm looking for just a couple of examples.
Yeah. I've been working here in the United States with teams. There's a number of folks who are working in different faith communities. We tend to work my lab with the American Muslim community, but my colleagues are working in, Christian, Jewish, Hindu, and Buddhist communities. And in all of those communities, it's been, there's been the moving of the needle is how I'd like to start describing it. It's a start that's happening. And part of the work that we do is actually the trainings of religious experts, leaders, individuals who hold their community's trust, and be able to then not give them clinical skills. That's not the goal here, but rather to help them develop competence around how to have a basic assessment of the mental health needs of the people that they minister to. And so what is it that how do you know when to refer? How do you know what the red flags are? When do you start kind of reaching out for support outside of yourself, where prayer won't be sufficient, or can be adjunctive to what it is that potentially that person needs? Also being very, very cognizant that there are some individuals for whom religion has been a source of pain and not a source of help. The religion that hurts or harms and religion that heals. This kind of concept and needing to be able to work with both types of experiences to be able to get that individual to the correct level of care that they need. So this is where our the trainings that we've been doing as part of this larger group has been excellent, and has become a subsection of the field of psychology and psychiatry. We call it RNS, or religion and spirituality in psychology or in psychiatry. And it's become
a new acronym for
me. Yes, it is. Yes, it's more of a recognized subfield, certainly than And I have to be very clear, there are individuals who have been working in this subfield for decades, but perhaps it wasn't as recognized as it is at this very moment, which again, thankful to see some of the changes.
Alistair, can we kick that question to you? You've worked in a number of different academic, but also policy institutions. What are you sort of seeing as the kinds of questions that are emerging, or really the sort of progress that, let's look at it positively, the
Yeah,
progress that's
absolutely.
been made?
Well, a couple of things. One, just related directly to what Rania was saying, I remember having a long discussion with Fahmi Hanna, who was chair of the MHPSS reference group for a number of years. And he had read some of the stuff we were doing, and he was saying he was wondering whether it was right to make the focus on making MHPSS more faith sensitive, or really about making faith communities more MHPSS sensitive. And at first, I was really irritated with that suggestion, because you sense from the passion of my previous answer that the sense to which secular institutions should awake to their own biases and the need for them to change and to be reflective, as Rania was noting, that is really important. But frankly, going back to my first answer, if people in the first place go to faith communities and actors rather than institutions, it makes sense to work in both directions and to be aware to foster this movement within faith communities, which is more sensitive to learnings and understandings around mental health. And I think I can point in the Christian and Muslim and other communities to a greater awareness. And I think there is absolutely, as you say, a generational effect there. And again, COVID clearly a significant factor, when in many traditions, this is a much more open question. The second quick reflection is that the word faith sensitive, I think, is both helpful and a hindrance. I think it's helpful in our taking our focus away from the faith of the provider.
Mm-hmm.
We're being sensitive to the faith of a population or a community. And that is everybody's business. You don't have to be a Muslim to understand the needs of a Muslim, or to recognize that a Muslim has spiritual needs, or a Christian or a Christian. And you can have no religion and be aware that someone in your program is spiritually suffering. And I think that's a fundamental point, that it's to be sensitive to these needs. And whether you can provide them yourself is a different matter. And I think quite often we're learning a lot now from a more of I call it a chaplaincy model, where identifying a need is not to presume that you can meet that need, but is to then triage and understand who in the community can provide support and help. And I've seen a number of developments of chaplaincy type models within humanitarian field and elsewhere. And then finally, I'd mention some specific developments. The one I'm actually most excited by is work at University of Washington and other colleagues on Islamic trauma healing, which is more than faith sensitive, because in a sense it's faith based. It's recognizing that within Islamic religious traditions, there are a number of elements which echo validated scientific approaches in terms of breathing exercises and trauma processing, and using parts of the Quran to reflect upon resilience, etc. And that quite deliberate, explicit melding of a scientific and religious framing, I think, is really quite exciting. That's been particularly working with Somali communities, both diaspora Somali communities in the US, but also in Somaliland. And I think that sort of approach, where the barriers between working across secular religious groupings are reduced and people work in collaboration, is very, very promising and very exciting.
Well, we're coming close to the time when we'll be addressing some of the questions that are coming from participants. But I did want to put to both of you a question of sometimes and this I think follows a little bit from the sort of crisis question, when a community as a whole is facing trauma, as you described it, or particular challenges. How do you see this sort of distinction between thinking of mental health in a very individual, personal level, or in a more societal or community level? And are there different approaches that you might take? Maybe Rania, I don't know if you from your from your research or studies whether there's anything that would be of interest. But Alistair, I know that you also have dealt with this issue in refugee and other settings, or where there's been a terrible crisis of some kind.
Sure, I'm happy to start. And, this idea of when there's collective trauma, when there's a number of things that are happening. And, the one that's coming to mind most readily at the moment is if I speak of the American Muslim context, I'm thinking of, Islamophobia. And what does that mean when an entire community of people are feeling a certain level of stress, discrimination, and a sense of just the sheer amount of what they carry with them on a daily basis, not knowing, will there be an Islamophobic event today that's going to, will somebody say something or do something to them today? And they just carry around that anticipatory anxiety everywhere they go. And what is the effect of on mental health, on the broader group, even whether conscious or subconscious? It's there. It's part of that experience. And so, how do you address the entirety of many people, many different types of communities, plural, that actually are experiencing the same type of distress? And so some of the work we've been working on actually is, in fact, first of all, naming that Islamophobia does, in fact, have mental health implications, and then looking at it in a nested model that starts, yes, with the individual, but it absolutely very quickly goes to the family, the familial level, the community-based level, and then from there, the societal level, before we go all the way to the global level. And then that nested model, that ecological kind of model that we think about, it's really important that all different parts of that model are addressed, each and every one of those. And if it's not, then there's going to be something missing, because you can have support potentially at an individual level, which is often what we think about in therapy, one-to-one kind of therapy. But for some people, that just won't do it. It's not quite hitting the mark, because this person isn't coming from an individualistic perspective. They're coming from a more collectivist culture or perspective, in which you need all the stakeholders buy-in in that healing process. And so very often our work isn't just in one-to-one therapeutic approaches, but in actually community-based healing. So the whole community comes together to be able to heal. And very often, to be honest, in this American Muslim setting, but also outside of this American setting, that happens within faith communities. When the community comes together, it's usually in their place of worship or in their community center, if it's a more cultural based community. And that's where some of this work happens, because on the individualistic level, it's not going to really lift the distress that's happening.
Mm-hmm. Alistair?
Yeah, just again, briefly, I mean, nearly 20 years ago now, 2007, the ISC Mental Health Psychosocial Support Guidelines, in there is about identifying forms of coping strategy and community healing. And I think often that's been paid lip service to, but without given the sort of the power that Rania's note is suggesting, that these are real factors. I'm aware of things like Tigrayan tea ceremonies that play a really powerful role in groups coming together at a time of loss and crisis and grief and reflection, and the potential for these to be a starting point of an intervention, not just an observation of something local, but really incorporating it within healing. And the work in Sierra Leone I was mentioning, I think the work on gender-based violence and work with women in that context, it is essentially a collective experience. There are clearly women in particular situations, but to understand it in a community collective has proved very valuable. And that's often bringing in broader community resources, which includes faith resources, to understand and to support and to frame that experience not as just your own battle to deal with, but something that the community addresses as a whole. So I think, again, in terms of that needle moving, or whatever the phrase was earlier on, the needle is also moving in that direction of recognizing that much of this experience is based within communities. Even if there is not a major traumatic event, often there are social determinants and social structures that make some groups much more vulnerable than others.
Well, it's time now to turn to some of the questions that we're getting. I see quite a few. We won't be able to get through all of them, but we'll certainly be trying to address them as we move forward. But one of the questions follows a little bit from what we're discussing now, which is, in a sense, the interfaith dimension of this. In other words, collective, working not with an individual tradition, say a Buddhist community, but really looking across the the spectrum through either the institutions, which can be at a community level or at a global level, like Religions for Peace or United Religions Initiative, or can take many different forms. But I'm interested in any perspectives you have on in answering this question about the interfaith as opposed to the ecumenical even, but also the sort of individual perspective. Maybe Alistair, maybe you can start with that one.
Yeah, I'm really happy to start. And just to reflect at perhaps initially at the global level, I think it plays down very much at local level. I've mentioned a couple of times the ISC guidelines of 2007 and was privileged around 2015 to be approached by Lutheran World Federation and Islamic Relief. So two very different organizations committed in the humanitarian space, but from different religious perspectives, who wanted to work together to demonstrate this commitment to potentially partnership across faith boundaries, if you like. And they could have chosen a range of topics, but they chose mental health, and they chose the idea of developing how we could make the implementation of the 2007 ISC guidelines, what prompts would to do that in a faith-sensitive way. And I have this little thing here, which a few people might have seen, that came out of that dialogue. But I'm proudest of two things of this document. One is that it has the two logos and actually several other logos on the front, which shows there was a commitment to co-working. There was so much in common here that drove this forward. But the other thing is that in terms of the guidance, so much of it is actually asking questions at a local level to say what is happening and can we bring this group together with that group. Now, inevitably, in some contexts, there will be some religious groups who are not used to working together, who, to link it to again your major theme, have a lack of trust with one another. And I think for me, that links back to the community organizing, good development principles. You don't start with the most difficult challenges. You work with partners that can work together and you build momentum, but you keep the door open. And I see a number of instances at a local level where interfaith initiatives have taken place and have gradually drawn in actors around the edges of that. And I think it's a very powerful and very important part of this. And again, it's sharing, it's bringing around the common understanding that faith is a key motivating principle. It's not about the provision of a particular faith perspective. It's about respecting the faith of communities and populations. Rania, I don't know if you want.
Another question that's coming out turns on a classic that we're all grappling with. I know both of you in many of your incarnations have dealt with the question of evidence. What's the evidence? But Ronnie, I'd be interested in trying to address a question that a couple of people have of, is there solid evidence? Either one person is focusing on sort of communal trauma of the ways in which a faith-sensitive or faith-informed or faith-driven response might have helped to bring progress or not. Or any other sort of evidence, solid evidence, research grounded things that we can point to that will help to eliminate some of the hesitations and prejudices that so many people have.
Yes, yes. And I think very early on in this work, came to realize that I needed to, well, have a lab, an academic research lab on the very topic. And it was precisely for this issue. Before my medical training, I was trained as a faith leader. I continued to be a faith leader. And what I found was that, for some segments of communities and societies, unless there was also this academic rigor that came with the work that we were attempting to do, sometimes honestly, to be very transparent, unless it had the big stamp of something like Stanford University or fill in some other major institution's name, it just wasn't getting traction and it wasn't being trusted quite enough. Funny enough, there's also the flip of that is also true, as in to say, had I not had my faith credentials, I couldn't do a ton of the work that I currently do. Something about that dual training was actually quite important. So those who are asking, is there enough evidence? I absolutely understand what that means because I've lived this experience. And a lot of the work that we do, the research we do, the studies, is really proving just that. We have a modality, for example, of psychotherapy that integrates Islamic principles into the modality of psychotherapy. It's called TIIP, traditionally Islamically integrated psychotherapy, or the TIP program. And the reason we did all this research and work around that, comparing it to your standard CBT, for example, cognitive behavioral therapy, was precisely to answer this question. Is it as effective when you start integrating faith? When you bring in faith principles or religious principles, spiritual principles into the mental health space? And the studies now that they're finally completed and we're able to actually show the data, that they are, for example, TIP, for example, is just as effective, if not more effective than CBT in this population. So I very much understand that's just one example of many, many that I could give, where it's very important where that the science behind it is also there, because ultimately they're going to be, members or sectors that are not going to think or believe or really continue to have that hesitancy of, shall we bring in the faith discussion into a otherwise scientific space? While of course I'll here push back a little bit and say all of psychiatry and psychology in itself has dealt, the entire field has dealt with that. Is this even a scientific field in the first place? So I guess we're having a dance that's very important here.
Well, we have very different understandings of what evidence is in different fields. Alistair, you might want to pick that up, but maybe you can add to it another sort of classic debate, which one of the questioners has raised between sort of faith leaders versus faith actors. In other words, who are we really talking about?
Yeah.
And, one of the phrases that people use is a person of faith, but to some extent, everybody has faith. The question is what
Yes.
they have faith in. So how do
Yes.
you distinguish who the people are, as you think, perhaps starting with the evidence issue, but going beyond?
Well, I think the two are linked in a way. I support completely what Rania was saying, and I think the evidence base is clearly growing. But like any mature evidence base, it isn't a yes or no answer. Is faith relevant or not? It's about how you use it and effective ways of doing so. So that the field is maturing in that way. And I, like many, I think, became a little concerned at one stage when the panacea was, did you engage faith leaders? Engaging faith leaders is good, not that that was the route to it. And I think it often shows a poor understanding of a number of religious traditions that if you can just get into the head of one or two faith leaders, you can somehow bring a whole population with you. And clearly, faith leaders have positions of influence. But in traditions where we might associate them as being male and in particular positions, that actually the diversity of leadership within communities, frequently female leaders, youth leaders, etc., there's a much broader understanding, I think, emerging of if you're addressing leadership within faith communities, there are a variety of actors within that space.
Yeah.
And more generally, the idea that faith in many communities is an issue of debate and contention. It's not something which is manacled and restrictive, which is the assumption from outside, but is often something that is part of moral discussions and debate, which therefore includes opportunities to discuss issues around mental health and well-being. So I think faith leaders are an important stakeholder, but potentially much too narrow a lens in terms of really understanding how to engage effectively within faith communities.
Well, we're coming close to the end, so I want to give each of you a chance to raise any issues, and maybe you could focus on maybe two questions in the next few minutes. One, I realize that we haven't mentioned something that's on everybody's minds these days, perhaps too much, which is sort of social media and how that's changing some of these conversations, in this case, faith and mental health. And then the second is sort of how do you build trust? We all know how easy it is to destroy trust, but are there either examples or wisdom or inspiration on building trust? Maybe I'll start with you, Rania, if you're ready.
Yes, of course. Yes, and there are a number of questions that are actually asking how do you do this exactly? And a mentor early in my career gave me some really great advice that I'd like to share here. And she said to me, "So you say you want to work with the Muslim community and help them work with mental health, and this is at a time where this discussion, I would say, was still very much stigmatized. And it was a difficult conversation to bring into the community, the communities at least that I was part of." But I think that reflected in many other communities as well. And she said, you say you want to do this. And I said, yes. She said, well, you're going to have to roll up your sleeves and, put your head down and serve the community first so that you are somebody they trust in the first place before you try to bring in a concept or concepts that are somewhat foreign and or seen as, not part of their reality. I said, okay. And so, to be very honest, a lot of that meant service, just being part of the community, showing up. And I tell this to so many other clinicians that I'm training, psychologists, psychiatrists, therapists, those who are in the allied mental health fields. I say, if you want to work in the community and you're hoping to build that trust, a lot of times it's you showing up, it's you being there, you're part of this community in the first place, so that when a crisis hits, they turn to you and say, well, we know who you are. And I can tell you, I never intended in my work to get pulled into suicide work. This is a difficult topic, and we often give a trigger warning before we speak of it. But I have done so much work in these last couple of years, specifically last 5, focused on suicide, which is, I would say, the taboo within the taboo of a mental health discussion, particularly in faith communities that often see it as a mortal sin. And bridging that conversation, or even bringing that conversation to our faith leaders and also community leaders. And it's been because of that trust. I'm a recognized face or someone who they can have seen and know. And the work, and even though the work has been contentious, as in to say some people are not happy with the work I do on suicide because they feel like it's having the community's dirty laundry being aired out in some way. But the reality is suicide is a reality, as is mental health a reality in all communities. And actually our success in getting imams or Muslim community and faith leaders trained. Now we've trained over 650 of them, which I'm very proud of. And it's been a lot of work rolling up sleeves and having them trained in knowing how to intervene, also how to work upstream, how to prevent. And then in the case of a tragedy, post-vention, basically after a crisis, how to help a community heal and grieve, because the reality is they are the ones on the front lines, not the clinicians, but they need that support to really understand how to do so. So our trainings on this topic have been incredible. And it's just taken a lot of work to be able to be part of community, earn trust, and then develop faith nuanced methods, whether that be research and or trainings. In this case, bringing together the Islamic ethics and morals and marrying that to the scientific evidence so that it's sound on both ends. And that way we have the stakeholders act their buy-in to actually be able to do this kind of work. So I hope that those examples, help those who are thinking about, well, how do I engage and earn trust of faith communities?
So service and trust, and it's a lot of work. Alistair?
Well, I just think Rania said so many important things there. Just to reinforce a couple, I think there is time involved in doing that. And I think Rania mentioned some things were contentious. And I think it's working through contentious things with people, with humanity and in solidarity, and probably also reciprocity. I see that at work very much in the city here, with a number of faith communities involved in refugee response, that it's engaging alongside each other in ordinary things, basic things, helping with the kids, helping with food, which builds some sort of shared space, shared understanding of each other, rather than feeling that it's a linear process of influence by someone with power and information to someone in a more vulnerable position. And I think there's so much now understanding around trust as being these cycles, these systems of trust building, which are really important in the local context in which we live, and also in international circumstances. I don't think we would ever have success with a 3-week trust building course or whatever that suddenly goes in and guarantees that you've now got partners. That it takes the hard yards, but is then a huge resource that then, because you've been through contentious times, and I'm now old enough to see patterns, in different contexts and different partnerships, that have been through a couple of wars together, have been through different cycles, and there is a richness of the trust that's established through that, which is a huge resource. And I see through Religions for Peace that you mentioned some really important work in terms of building those sorts of partnerships that sometimes have to address difficult and challenging opportunities, but it's through that strength can be trust can be strengthened.
Well, I'm afraid we need to pass this back to Diana, but this has been a very rich discussion, a lot of questions we haven't been able to address for time limits, but we will be looking at them and we'll be coming back to them as well as to you. So my thanks to you, and over to Diana.
Thank you.
Thank you so much, Catherine, Alistair, and Rania, so much for this rich and engaging discussion. And thank you to our audience, of course, for your thoughtful questions and for being a part of this conversation. I think what really stands out to me is how important it is to keep creating spaces like this that bring together these different perspectives and really recognize and spotlight the role of community and lived experience in shaping conditions like mental health, but also other health issues that we'll hopefully cover in future webinars as part of our series. So we want to invite you as the audience to stay engaged with the Georgetown-Lancet Commission on Faith, Trust, and Health through our website and newsletter. We'll drop a link in the chat for you to sign up there. And our webinar series will continue in the coming months, and we'll be hosting virtual listening sessions that are open to all, so you can give some insight and perspective on these themes. Thank you again to our speakers, to all of you for joining us, and to our team at the Global Health Institute for making today's event possible. Wishing you all the very best, and we hope to see you again soon.